Hello, my name is Tatsuya Kim, Director of Clinical Islet Laboratory at the University of Alberta, Canada. I would like to thank Professor Kemochi and the Congress organizers for the opportunity to give a talk today. Over the next 30 minutes, I'm going to talk about islet isolation and transplantation in a real-world healthcare setting, mainly focusing on what we have done at what we are doing at the University of Alberta. I have nothing to disclose. I would like to start with this slide. This shows the activity of islet isolation and transplantation over the 37 years at the University of Alberta. The white bar indicates the number of islet isolations per year, and the black bar is the number of transplant procedures per year. The first human islet isolation was performed in 1984. First of all, I want to show you what was done before the Edmonton Protocol. During the pre-Edmonton Protocol era, 7 islet transplants were performed. This gentleman became the first islet transplant recipient in Canada in 1989. You may recognize Ray Lajot and Gus Warnock here. Both of them are my mentors. The number on this sign, held up by Ray Lajot, is 100. It took 100 human islet isolation to perform the first transplant. Huge effort. Here is a summary of 7 cases. During those days, islet transplant was considered an experimental procedure. Therefore, islet transplant was combined with other organs, mainly with kidney. Also, it was difficult to isolate enough islet mass from a single donor pancreas. So, cryopreserved islets from multiple donors were added to obtain critical islet mass. Among 7 recipients, case number 3 and case number 5 achieved insulin independence. I'm going to show you details on case number 5. The patient received fresh islets combined with cryopreserved islets from 5 donors. Here is an islet counting record completed by Ray Lajot. During dynamic perfusion study, you can see a robust insulin secretion responding to high glucose in fresh islets as indicated with the black circles, and in cryopreserved islets as indicated with the white circles. Here is a record of transplant. Initial portal vein pressure was 15.5 and final pressure was 17. As you can see from this record, a syringe was used for infusion. This is a record of C-peptide levels after transplant, and the patient with Gus Warnock and Eddie Ryan. Islet graft function was maintained at least 13 years after transplant. Her kidney functioned very well, but at 5 years, her kidney graft was rejected, and she required another kidney transplant. But interestingly, her islet function remained well. The episode of kidney rejection suggests that her fresh islets from the same donor as the kidney had been rejected or subjected to autoimmune destruction. So my speculation is cryopreserved islet contributed to her long-term graft function. Interesting case. Now, During this time period, there was no clinical transplant due to funding and other logistical issues. However, 122 human islet isolations were performed during the 3 years. My mentor, Ray Rajot, often said, "Complete your study. Don't stop it." He didn't stop islet isolations during this difficult time. I moved to Edmonton from Japan in June 1998 and had the privilege to work for the development of Edmonton Protocol with many pioneers at the University of Alberta. The first transplant under the Edmonton Protocol was done on March 11, 1999. It was home run. Insulin independence in 7 consecutive patients with type 1 diabetes. Amazing result. One thing I would like to mention here is that although I was considered a visiting researcher at that time, I was acknowledged in the New England Journal of Medicine paper. The response was huge and quick. Immediately after the release of the Edmonton Protocol, Bill Clinton decided to start a multi-center clinical trial to replicate the Edmonton Protocol, so-called ITN trial. The Edmonton Protocol became very well known. The Edmonton Protocol is described in a biology textbook for high school students. At drugstores in the city, a pamphlet for islet transplant is available to general public. The name of Edmonton became well recognized, but I found one minor issue. It is a University of Edmonton. Such a university does not exist in the world. There are many published papers describing the University of Edmonton, just for mistake. Edmonton is the capital city of Alberta. University of Alberta is located in Edmonton, just to confirm. Now, I believe that what you want to know is what happened after the initial report and what is the current status of these 7 patients. Here is a long-term follow-up result. Patient number 1 died of stroke 17 years after transplant. He was 71 at the time of death. All patients, except for this patient number 3, went back to insulin within 5 years after initial transplant. Importantly, patient number 3 is still enjoying insulin-free for 22 years. Excellent outcome. Back to this slide again. As Ray Rajot said, complete your study, don't stop it. We continued to transplant with further refinement. In 2006, we modified our induction protocol using alemtuzumab. For maintenance immunosuppressive therapy, Cercept and tacrolimus are used. In addition, as anti-inflammatory agent, etanercept and anakinra are administered. In June 2019, we started subcutaneous alemtuzumab instead of intravenous injection in order to minimize acute side effect of alemtuzumab. With these modifications, insulin independence rate at 10 years is 27% in alemtuzumab group. Overall graft survival in all patients in Edmonton is now 62% at 19 years. insulin independence using a single donor is the most desirable outcome, we all know that the primary goal of islet transplant is elimination of hypoglycemia. However, in my opinion, we should stick with insulin independence. 20 years ago, achievement of insulin independence after a single islet transplant was not common, and the rate was less than 20%. In the recent 3 years, almost half of the recipients became insulin independent after a single infusion. This improvement is largely due to a higher islet mass transplanted. Indeed, 20 years ago, I was so happy when I got 300,000 islet equivalent. Nowadays, 300,000 does not make me excited at all. This paper was published in 2014, and as you can see from this Kaplan-Meier curve, insulin independence does not last long, unfortunately. Good news is that this patient is still enjoying insulin-free after a single transplant. 12 years now. Again, islet mass is significantly important in graft outcomes. Functional assay does not give us useful information. One thing I'm going to mention here is that we set this bar at 5,000 IEQ per kg 20 years ago. I want to remind you that there have been no changes in this bar for 20 years, in spite of improvement of islet isolation outcomes. I'm confident that we can set this bar higher, for example, 6,000 islet equivalent per kilogram. I have been wondering whether islet transplant provides survival benefit or not. Answer is, I don't know. We just don't have enough recipients waiting for islet transplant as a comparator. We lost 27 patients for a variety of reasons, and the 20-year survival rate is 82%. When we compared patient survival rate between islet transplant alone and islet after kidney, we didn't find significant difference between two groups, but I'm not sure if this comparison has a real meaning. I just wanted to share our data with you. Now, I'm going to talk about the dark side of islet transplant. As you know, undesirable or unexpected events sometimes happen. For example, we received the kidney instead of the pancreas in 2 occasions. And one time, the pancreas was sent to a wrong city by mistake. We canceled 3 transplants due to a significant loss of islet mass after culture. Regarding a transplant procedure, portal vein cannulation was not accomplished in 4 cases. Fortunately, 3 preparations were eventually transplanted. Finally, we had 4 cases of canceled transplant due to abnormal testing results. These abnormal results could have been pointed out prior to induction therapy. This is a real-world situation. Now, I switch a gear to pancreas donor. In Canada, the number of donor offers is increasing as shown here. Both brain-dead donor and DCD, donation after cardiac death donor, are increasing. At the same time, we are declining more donor offers. Why is that? Do we accept only high-quality donors? My answer is no. For example, we accept older donors with oldest being 82 years. We still process donors with A1C greater than 6.5% in some occasions. Many lean donors were processed as well, and the longest cold ischemia time was 24.5 hours. I just wanted to show you the outcome of an 82-year-old graft. This is an islet after kidney patient, and he received his first transplant from a 72-year-old donor with 10,000 IQ per kg. His insulin requirement went down from 34 to 11 units per day. 1 month later, he received his second transplant from an 82-year-old donor with more than 6,000 IQ per kg. Then what? Off insulin. He is still insulin-free. Back to declining offers. Bottom line is that we don't have enough recipients in our waiting list. Many donors are declined because of no ABO-compatible recipients or no virtual cross-match negative recipients. Previously, we had many recipients from all over the country, but in 2007, the Alberta government decided not to accept patients who live outside of Alberta because of financial issue. As a result, our recipients are limited in Albertans with only a few exceptions. This is ironic because we accept donors from outside of Alberta, but no recipients from outside of Alberta. Here's a snapshot of our recipient list. There are 1 blood type A and 6 blood type O potential recipients in the list, with no Bs and no ABs. All recipients except for one are highly sensitized due to previous transplants or other events. One day, we had an offer of this blood type O donor. This non-sensitized recipient was listed just 3 days ago, and we found that this patient was virtual cross-match negative. We accepted the donor and then transplanted. What happens next is that we will have to continue to decline many donors until a non-sensitized recipient is newly listed. This recipient shortage is a chronic problem and is ongoing. This is a Kaplan-Meier curve showing how quickly patients undergo transplant once listed. If patients are not sensitized, waiting time is 1 to 2 weeks. But if sensitized, highly sensitized, patient must wait years and years. Well, interportal transplant is often blamed because of several reasons, including instant blood-mediated inflammatory reaction. Extrahepatic site has been a hot topic in Islet community. We have conducted 3 clinical trials investigating extrahepatic site. However, the results were unsatisfactory. First one, was subcutaneous islet transplant using an artificial pouch. Insulin-positive cells were detected in histological examination, but no graft function, no C-peptide secretion was detected at all in all 3 patients. Then we tried gastric submucosal transplant in 2 patients. We observed some degree of graft function in 2 patients, but no insulin independence was achieved. Lastly, we performed omental pouch transplant in 4 patients. Again, we observed reasonable graft function, but no insulin independence was achieved. Subsequently, 3 out of 4 patients received interportal transplant, and all 3 patients became insulin independent after a single interportal infusion. And 2 patients are still insulin-free. I cannot make any conclusions from our small 3 studies, but when it comes to extrahepatic side, the omental pouch appears to be promising. Now, switching a gear to the future and the ongoing clinical trials. My colleague, Andrew Pepper, did a transplant study using human embryonic stem cell-derived pancreatic endoderm cells. Here is an overview of the protocol of the 4-stage in vitro differentiation of human embryonic stem cells into pancreatic endoderm cells. He transplanted these pancreatic endoderm cells into immunodeficient diabetic mice and showed that pancreatic endoderm cells were able to reverse diabetes in all recipient mice. Pancreatic endoderm cells became matured endocrine cells in vivo, as you can see abundant insulin-producing cells. Now, these human embryonic stem cell-derived pancreatic endoderm cells are manufactured in clinical scale by a company, ViaCyte. Probably many of you know that ViaCyte is a leading company in regenerative medicine. They developed a device containing human embryonic stem cell-derived pancreatic endoderm cells. The first trial with ViaCyte was using macroencapsulation device called PEC encapsulator. This is an immunoprotective device, so immunosuppressive drugs were not given. We started this trial in August 2015 and completed implant and explant in 7 cases. Subsequently, ViaCyte developed an open-type device which has no immunoprotective ability and called PEC Direct. We completed implant and explant in 12 patients under immunosuppressive therapy. Another clinical trial we are conducting is so-called prevention study. We are recruiting patients who are newly diagnosed type 1 diabetes. First, T-cell depletion is done using alemtuzumab, and the following day, we give plerixafor for stem cell mobilization for immunologic reset. Also, we are hoping regeneration of beta cell through liraglutide administration. We treated 18 patients so far, and this trial is still ongoing, so details of the results will be released in the future. In summary, Both islet isolation and transplant outcomes have been improved over years. There is no question about this. Interportal engraftment is still the gold standard in islet transplantation. I think we have been putting too much effort on extrahepatic site. Recipient shortage. In Asian countries, this is not true, but true at least in Canada. We still have been struggling with a single donor insulin independence. Higher islet mass cutoff value should be considered for further improvement. For example, 6,000 IEQ per kg as a minimal mass for transplant. Finally, what we should do is to complete our study one by one. Don't stop it. There are a lot of optimism in the future. Thank you for your attention to this talk. If you have any questions, please send me an email. 감사합니다. 谢谢。ありがとうございました。